lecture just to give you a feel for what normal is. And so all the epithelia of the female genital tract are under hormonal influences. So there's, they're going to vary throughout the menstrual cycle. So early in the cycle, you get estrogen influence. Later on, you get progesterone influence. And all of the female genital tract basically has receptors for that, for those hormones. So the squamous epithelium comes from two different embryonic origins. So the epithelium lining the labia majora in the vagina up to the level of the hymen originates from the urogenital sinus, and the remainder, the back part of it, is derived from the Mullerian ducts by transformation of cuboidal epithelium into squamous epithelium, which is a metaplasia. Anytime one epithelium changes into another type, that's called metaplasia. All right, so there are layers. In the stratified squamous epithelium, you have a basal layer, which is where the cells divide. So that's the source of all the cells that regenerate. And then there are a single row at the bottom of the epithelium, essentially. And then in between that and the superficial is the intermediate layer, which is the bulk of the thickness of any stratified squamous epithelium. This is where the epithelium matures and starts to take on keratin and the things that protect, that allow the epithelium to protect what's under it. So there are cells that are closer to the base that are smaller overall, and they're called parabasal, and then as you go up, they're called intermediate cells. And then the superficial layer contains the most mature cells, the superficial cells. These are the ones that are orange on the pap smear. And they are sloughed off by a process that's called exfoliation or desquamation. And in the female genital tract, aside from the labia majora, it is non-keratinized, which means it still retains its nucleus all the way to the top until it's exfoliated. If it's keratinized, then the nucleus gets extruded and all that's left is basically keratin in the cell. And that's only seen in the female genital tract, that's only seen in the labia majora, basically where there's skin. So stratified squamous epithelium is generally non-keratinized in the vulva and vagina, and that's what you see here. You can still see nuclei all the way to the top. And then you have all these intermediate squamous cells, and down close to the base you have these parabasal cells, and finally you have the basal cells at the very bottom. So the basal layer, again, is a single row of small epithelial cells. The nuclei shows some evidence of active cellular growth. If you look close enough at the basal layer, you'll often find nucleoli or mitotic figures, and that's to be expected in that layer because that's what's regenerating. Generally, regeneration should be confined to the basal layer. The only time you'll see it above that is in reactive or dysplastic states. The intermediate layer, again, is composed of maturing squamous cells that are bound to each other by well-developed desmosomes. These are little spinous processes that you can see. Often, especially if there's edema or any kind of reactive thing, you'll see them stick out really well, the spiny processes. And those are called desmosomes. That O shouldn't be there. Desmosomes is, that would be desomosomes, but anyway. With maturation, the amount of cytoplasm per cell increases. So the nucleus, say, is fairly constant and even gets a little bit smaller right when it becomes a superficial squamous cell. The cytoplasm will increase, though. So you should see a decreasing overall NC ratio as you mature. Superficial layer is composed of several layers of loosely attached cells. The nuclei become small and pycnotic, and then they are not capable of any further growth. So once you've gotten to that point, once the nucleus becomes pycnotic, you can't make any more protein, so it makes sense. The cell isn't going to grow any further. And then they're cast off by exfoliation. So the vulva consists of the mons pubis, labia majora, labia minora. Labia majora is the part with skin. Labia minora is the part that looks like the inside of the mouth, the oral mucosa. Then there's the clitoris, the vestibule, which is just the skenes and Bartholin's glands, which line that area. Skenes on top, Bartholin's on the bottom. Mons pubis is keratinized, so that's skin, essentially. And it has hair-bearing skin, so all that. Labia majora, again, pigmented keratinized stratified squamous epithelium. Depends on the pigment status of the individual. Dermis with hair follicles has sebaceous, has apocrine glands. Apocrine glands are a specialized kind of sweat gland. They're seen there, they're seen in the armpit and along the groin. And then clitoris is non-keratinized, vestibule same. Skene's glands are ducts, so they're lined by cuboidal epithelium, and then the glands are pseudostratified columnar. Bartholin's glands, very similar in appearance. They tend to be lined by transitional epithelium, kind of similar to the bladder. Okay, so this is your keratinized stratified squamous epithelium. Now, so once you get to the top, you have no nuclei anymore, and you've got what's called a horny cell layer. The cornified layer is a better term, stratum corneum. And then you've got granular cells that have dark blue keratohyalin granules. Your squamous cell layer, which is really usually called a stratum spinosum or spiny cell layer, and then you have your basal cell layer. In the skin and in the vulva, in the labia majora, you have these individual melanocytes, which send processes that pigment all the cells in the area. And they're usually picked up, they're usually a little lighter staining on the H&E, so they're usually pretty easily seen. Then the Langerhans cells are actually immune cells of the skin. Those are not so easily identified on H&E sections, and usually you have to do an immunostain like a CD1A or something like that to pick those up. So this is what stratified keratinized squamous epithelium looks like. This would be like labia majora. So you have underneath, you have a hair follicle, you have sebaceous gland, you have often the supporting muscle, which is called the erector pili muscle. That's the muscle that gives you goosebumps when the hairs stand up. Those are the smooth muscle cells that do that. And this is your basal cell layer again, right here at the bottom. If you look carefully, often you can catch a mitotic figure or two along the base. Then you have your parabasal cells just above that, your stratum spinosum, your granular cell layer, which is these dark blue granules right here. Then occasionally, especially on fingers and toes, you'll see something called a stratum lucidum, which is a clear cell layer. It's a little bit less obvious here, and then finally your stratum corneum, which is no nuclei are generally seen in this area, and it has a basket weave pattern, where all that's basically there is keratin. All right. So moving on, the vagina is non-keratinized, so that stratum corneum is not present, and generally the granular cell layer is not present either. It just ends at the top of the stratum spinosum. There's abundant intracellular glycogen, and it is hormonally responsive, which means it changes with the cycle. As you get an estrogen cycle, it becomes more full and matures more, so you get more of those superficial cells. And then as the progesterone part of the cycle comes into play, you get less maturation and you get more intermediate cells relative as a ratio. So the lamina propria tends to have dense and some loose connective tissue with a lot of veins and a lot of lymphoid aggregates. So there's a lot of need for immunity in that area just to keep things from infecting. So you see a lot of lymphoid cells that are doing that, basically the gatekeepers. So there's a lot of transverse folds or rugae, particularly early in life or during childbearing years, and that tends to decrease after menopause. In the muscularis, you have two layers, an intercircular layer and an outer longitudinal layer. And then there's a skeletal muscle sphincter at the introitus. And then the introitus is just like the vestibule. It's basically the entry. And then adventitia is is a firm, elastic inner layer and outer loose connective tissue. So we use the term adventitia when there's not peritoneum or a serous lining covering a surface, so on an outer edge of something, so that the vagina is down past where the peritoneum ends, so we call that adventitia. When we get up higher, where there is a peritoneal lining, we're going to call it serosa. So you'll hear serosa of the uterus and adventitia of the vagina, and so that's why the difference in the terminology. All right. So the vagina is lubricated by mucus that originates from the cervix. There are no glands present in the mucosa of the vagina normally. There is an abnormal condition called vaginal adenosis where you can see them, but in normal patients there should be no glands. The epithelium doesn't keratinize generally. If it does, that's also abnormal. It's called hyperkeratosis if it does. Again, no glands or muscularis mucosa present within the mucosal layer, and it's chiefly smooth muscle, and it's not particularly well ordered. So it's not as obvious as like the uterus, for instance, where the smooth muscle is in bundles. So here's a cross-section of the vagina, non-keratinized squamous epithelium. So you still, again, you have your basal cell layer lining the bottom. You have some capillaries that come up into the epithelium, but there's still stroma with them, and there's a basal layer around those. Then you have parabasal cells above them, you have intermediate squamous cells above them, and at the very top you'll have a layer of superficial squamous cells. Again, non-keratinized stratified squamous epithelium. If you do see keratinization at the top, that's hyperkeratosis, something we'll talk about a lot more in the PAPS when we get to that. And underneath is mostly dense connective tissue, but there are some smooth muscle bundles underneath that if you get a deep enough biopsy, like here. And again, you can see the smooth muscle demarcation pretty nicely here. So there are smaller bundles and less organization as you get up to the top, but then there are nice big bundles towards the bottom of the thing. Then there's dense connective tissue here, and again, basal layer, parabasals, intermediate squames, and superficial squames. Okay, so continuing up the female genital tract, we come to the uterine cervix, which is divided in parts into the ectocervix. That's the outer part, usually the part that is visible on speculum exam. It's the lower or most distal portion of the cervix that lies within the proximal vaginal canal. So non-keratinized stratified squamous epithelium looks very similar to what you see in the vagina. Then there's a transition zone or transformation zone. That's the junction between the squamous epithelium of the ectocervix and the glandular epithelium of the endocervix, also called the squamo-columnar junction. This, on colposcopy, when it's visible, is usually, there's kind of a almost flesh tone to the ectocervix, and then it gets a darker pink color as you get into that glandular area. The endocervix is the part of the cervix that faces the endocervical canal and is a simple columnar glandular epithelium. And this zone, this transformation zone, does move with the course of one's life, and we'll talk a little bit more about that as we get into PAPS and interpreting PAPS. Intermucosa is, again, of the ectocervix, the intermucosa is non-keratinized squamous epithelium. It is, of course, hormonally responsive like everything else. Then the muscularis layer, the smooth muscle layer of the ectocervix, is continuous, moves up and is continuous with the uterine myometrium. They're interwoven bundles of smooth muscle, somewhat more organized than those of the vagina, and they're enmeshed within a dense fibrous connective tissue, which gets looser as you move up the uterus. The epithelium, again, is the same as the vagina, non-keratinized squamous epithelium. The same applies also if you do see keratinization, we call it hyperkeratosis, the same as with the vagina. The junction between the epithelium and the underlying connective tissue is a little bit more even than that in the vagina. There is an undulating, kind of irregular appearance to it. And there are no glands generally within the mucosa of the ectocervix. Now when we get to the endocervix, that's different. So this is what the ectocervix looks like. Could you tell ectocervix from vagina just based on section alone? Not really. Still have dense connective tissue underneath. You have the basal cells, parabasals, intermediate squamous cells, and up at the top, the superficial squamous cells. And notice, as I was telling you, the nucleus gets a little bit smaller and more pycnotic, so you see these superficial squamous cells darker, smaller nuclei than you have on the intermediates, and that's expected. Okay, so the transition zone, again, is that junction between the squamous epithelium of the ectocervix and the glandular epithelium of the endocervix. It's usually a very sharp demarcation in a normal cervix, but as you can undergo metaplasia or dysplasia, it will become less sharp. And that's a clue sometimes to the presence of dysplasia. But it can just be seen with metaplasia. So again, designated squamocolumnar junction, it can vary. It can be deep inside the endocervical canal, particularly in women who aren't sexually active. You'll see that. It can be present at the external os, which is generally what you see in young women who are childbearing age. And it can go to the surface of the portia vaginalis. So it can be out pretty far, or it can go up into the endocervical canal. Several. This is what it looks like. So you have these nice tall columnar cells. This is the endocervix here. And once you've moved into the squamous epithelium, that's the squamocolumnar junction right there. And you notice how sharp that is? That's the normal state of affairs. But as you get metaplasias or as you can get dysplasia, this will become blurred a bit. The endocervix, the inner mucosa is a single layer of mucus-producing glandular simple columnar epithelium, tall, clear cells, basally oriented nuclei. You can occasionally see ciliated cells in there, especially if they have tubal metaplasia. You can see ciliated cells. Regeneration occurs from basal or reserve cells. We usually use the term basal when there's only one type the cell is becoming. So if basal cells, for instance, are the base of a squamous epithelium, we tend to use the term reserve cells when there are two possibilities. So this cell could end up becoming a squamous cell, it could end up becoming a glandular cell. It has the potential of being both. That's when you hear the term reserve. These cells are usually relatively inconspicuous and again at the base of the layer. Endocervical glands are of a simple tubular branching type. They extend into the underlying connective tissue of the endocervix. And if they're cystically dilated, we call them Nabothean cysts. They don't tend to undergo cyclic loss of tissue, so this doesn't slough off like endometrium does with menstruation. Muscularis is continuous again with the myometrium of the uterus, and they're interwoven bundles of smooth muscle within this fibrous connective tissue framework. So again, you have these nice columnar cells with nuclei that are all at the base of the cells and abundant mucin above. There is, here you can see at the top, there's kind of a pink line. That's terminal bar. Sometimes you will see cilia on these cells. There's kind of a hint of that occasionally. And then underneath you have a dense connective tissue. These are the tubular glands that extend into the connective tissue. You see more of them in some areas than others. Sometimes they're present in clusters. You might hear the term tunnel cluster. When there's a deep cluster of endocervical glands, that's a name sometimes given to them. Now, this is the cervix. So we've got the squamocolumnar junction. That's what the columnar epithelium looks like. And then you also have in the endometrium, you have cycling, but in the cervix, generally you don't. There is a change in the epithelium, but it doesn't come off like in the uterus. So the uterus itself, the uterine corpus, which is what we use to distinguish it from the cervix, we'll say corpus and then cervix, is divided into three regions: the endometrium, which is the epithelial lining, the myometrium, which is the muscle layer, and the perimetrium, which is the serosa. Now, since we've got a peritoneal covering on the uterus, we use the term serosa here instead of adventitia. The internal os is the junction of the endocervical and the endometrial glandular epithelium. So you have your endometrium, which is the glands and the supporting stroma around the glands, which go down to a base, which the base of the endometrium sticks around through menstruation. The rest of it gets sloughed off. Then under that, you have the myometrium, which is all just interlacing bundles of smooth muscle. And then finally, at the outer edge of the uterus, you have the serosa, which is lined with a simple mesothelium, as any peritoneal lining is. The endometrium is a simple columnar epithelium that may be ciliated. Tends to have a little bit less mucus than what you see in the cervix. A cellular connective tissue, so it's a little bit looser and more cellular than what you see in the cervix. It's not quite as dense and pink, collagenous. There are large numbers of tubular glands, which are your endometrial glands, extending from the surface into the underlying stroma. This is in the proliferative phase, early in the estrogen part of the cycle. You'll get these nice straight tubular glands. And you'll see this in the lower uterine segment too, where the stroma becomes a little bit looser and not as dark pink as you see in the cervix. So the endometrium is also divided into a stratum compactum, your surface layer, the stratum spongiosum, which is in an intermediate zone of looser connective tissue, and then the basalis, which is the part that doesn't go away with your menstruation. So you leave that, and that's the part that proliferates again to recreate the endometrial lining every cycle. The compact and spongy layers are the ones that are shed, and then the myometrium underneath it is just interlacing fascicles of elongated, eosinophilic smooth muscle cells. The nuclei tend to have rounded ends, look cigar-shaped. So that's how you can often tell it from like fibroblasts of the connective tissue. Serosa is again visceral peritoneum, a single layer of flattened mesothelial cells. So the cyclic changes in the endometrium, as you have your menstrual phase where everything gets sloughed off except for that basalis, and then you have proliferative, the estrogen-dependent phase, where the endometrium is reconstructed with straight tubular branching glands, and then the secretory phase where they produce a thick mucousy material that allows for implantation, maximizes the potential for implantation if a fertilized egg should come down. After the deciduous sloughed off, you get resurfacing of that raw tissue, estrogen, and then progesterone. And the progesterone, the estrogen and progesterone are basically made by the ovary, so the ovary is producing all that. Estrogen is made by granulosa and thecal cells, which we're going to get into in a little bit here. And then once the follicle is ruptured and the egg is released into the fallopian tube, what's left over is called the corpus luteum, and the corpus luteum secretes progesterone, which is going to cause that secretory change in the endometrium and get it fluffy and ready to implant basically a fertilized egg. So here, this is right after menstruation. You have your basalis here and a very small amount of functionalis that's starting to proliferate and produce straight tubular glands. As you get into the later part of the proliferative phase, the straight tubular glands start to become a little bit more corkscrewy. And then as you get into the secretory phase, you'll start to see the secretions of materials. First, you have subnuclear vacuoles in the endometrial glands, then they become supranuclear, and then they finally secrete their material into the lumens of the glands. So once again, you have a proliferative phase, straight tubular endometrial glands, a cellular-looking stroma, and you'll be able to find mitotic figures relatively quickly in both. That's why it got the name proliferative phase. So there's a mite in the endometrial glands, there's a mite in the stroma, there's another mite in the stroma, so on and so forth. Once you get into the late proliferative phase, the glands start to become more corkscrew, you start to see early eosinophilic secretions, and the stroma becomes loose and edematous. After ovulation, the cells start to produce vacuoles. First they're subnuclear, and then they become supranuclear, and then eventually they secrete material, and that's the late secretory phase, the point where implantation is maximal, or the potential for implantation is maximal. So the fallopian tubes, continuing our journey, the fallopian tubes have an inner mucosa made of simple columnar epithelium that has both ciliated cells and non-ciliated secretory cells, and a cell called PEG cells, which are cleared out intercalated cells. And then you have underneath that a lamina propria and a muscularis, which has a thick inner layer and a thinner outer layer. The serosa, again, is covered with a peritoneal lining. So this is what it looks like. You've got a very highly branched and lined with columnar epithelium lumen, surrounded by 2 layers of muscle, smooth muscle. And then you have this outer loose connective tissue, and finally your serosal lining, which is covered with peritoneum. So mucosa, within that is the epithelium and the lamina propria, and then your muscularis layer, and then your serosa. Now once you look up close at the epithelium of the fallopian tube, you have most of your cells are going to be your ciliated cells, and then very occasionally you'll see a cleared out cell. There's not really great examples here, but every once in a while you'll see a non-ciliated cell, which is called a PEG cell. And this is your mesothelial lining of the serosa, usually a simple squamous lining. So now the ovaries, the surface of that is also a modified mesothelium, modified in that it's responsive to hormonal influences. Then you have the tunica albuginea, the outer zone, which is the cortex, which has a stroma, which has whorls of blue spindle cells, and numerous oocytes. That varies with age. The oocytes are very numerous in an ovary of a newborn, and then through a process of atresia, of pruning, essentially, the oocytes are decreased to around 400 by the time you reach childbearing age. So the inner zone is called the medulla, and it's vascular and has a network of tubules, if you catch just the right section, called the redia ovarii. Okay. Then the follicle development. First thing you have is your primordial follicle. That's the one you see a lot of in newborns or in children. And then when that follicle starts to mature, you have what's called a primary follicle, a multilaminar follicle. The clear space comes out between the egg and the rest of the follicle, called the zona pellucida. And then you have your theca folliculi, which is a set of theca cells, interna and externa. The externa are a little bit more plump. And then the granulosa cells, which make collections bodies. The secondary follicle is where you really see that granulosa cell proliferation, and you'll get a fluid-filled cavity and this heaped-up pile of granulosa cells on the side that the egg is on, called the corona radiata. And then as that matures into a full Graafian follicle or a mature follicle, the granulosa cells mound up further and become the cumulus rufers. Okay, so ovulation is day 14 of the cycle. That's the midpoint between menstruations. And then corpus luteum secretes progesterone and estrogens, but more progesterone. It's called a yellow body, even though it looks really orange more than yellow. Secretory granulosa lutein cells and secretory theca lutein cells. And these are both plumper than what you see in the follicular phase. It lasts about 14 days if fertilization does not occur, and if fertilization does occur, the corpus luteum actually expands and is stabilized, and it's called the corpus luteum of pregnancy. Once the corpus luteum is involuted, it becomes a scar, which is called corpus albicans, or white body. This is what a corpus luteum looks like, and like I said, it's really more orange than yellow. Some of the more plump ones are yellow, but usually more orangey, but whatever. So here's your ovarian cortex. Again, you have this blue whorly stroma, and then you have follicles interspersed in women of childbearing age. And then the medulla is basically denser connective tissue with vessels, and if you catch a good section in the hilum, you can see the redia ovarii. Again, this whorled blue stroma at the ovarian cortex and lining by a specialized mesothelium. Here you have primordial follicles. That's your zona pellucida here, around the clear area around the egg, and then you have the beginning of theca interna and externa cells. Same thing here, primary follicle. And then as it becomes a secondary follicle, you start to get those theca interna and externa cells. And then as the follicle finally matures, you get that pile of granulosa cells around the egg, and you get this big cystic cavity. Oh, and here are the theca cells as they're starting to become what's going to become the corpus luteum. This is a big Graafian follicle. You've got that whole cumulus superis, and you can see that clearing out here. That's the zona pellucida, theca interna and externa cells, and then your granulosa cells around that. And this is the big follicular cavity. Okay, and again, this mound of granulosa cells is called a cumulus superis. This is the corpus luteum after the egg has been released into the fallopian tube. You'll get these theca cells get really big and plump and secretory and make progesterone and some estrogen. And then after, either after no fertilization occurs or after pregnancy, if it did occur, you end up with a white body left behind called the corpus albicans. This is what happens usually around menopause. You'll just have an ovary with a bunch of corpus albicans and vessels and not much else. So again, the ovary, you've got your primary follicles, your secondary follicles as they grow, and then eventually they become the Graafian follicle, the mature follicle. And as that follicle releases its egg, it eventually becomes the corpus luteum and then the corpus albicans. And that's it. Easy peasy lemon squeezy.